Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 524 of our pharmacotherapy series, which majors in renal dialysis. The first case reads, DOB, a 56-year-old, 75-kilogram woman who undergoes high-flux hemodialysis 3 times a week develops fever, chills, and leukocytosis. So my first question to you reads, what are your recommendations for empiric antibiotic therapy for suspected hemodialysis catheter-related infection? The correct response is antibiotics that permit dosing during or after each dialysis session, or antibiotics whose pharmacokinetics are unaffected by dialysis, should be chosen. Treatment usually is initiated with vancomycin 20 mg per kilogram loading dose infused during the last 60 to 90 minutes of dialysis, and then 500 mg during the last 30 minutes of each subsequent dialysis session, depending on the type of dialysis being used. High-flux dialysis results in greater removal of vancomycin than conventional dialysis. Intradialytic dosing of vancomycin is a convenient mode of drug administration in patients receiving high-flux dialysis. It avoids the need for additional intravenous access, longer stays in the hemodialysis unit, or home antibiotic administration. Cefazolin 20 mg per kilogram after each dialysis session can be used instead of vancomycin in dialysis units with a low prevalence of methicillin-resistant staphylococci. Empiric antibiotic therapy should also include coverage for gram-negative bacilli, with antibiotic selection based on the local antibiogram. For example, gentamicin, or tobramycin, 1 mg per kilogram, not to exceed 100 mg infused after each dialysis session, can be used for empiric gram-negative coverage with appropriate serum concentration monitoring. The next question reads, what are your dosing recommendations for intravenous vancomycin and gentamicin therapy for DOB, and how are the infusions prepared? DOB weighs 75 kilograms. Therefore she should receive a vancomycin loading dose of 1,500 mg. Parenteral vancomycin is prepared by reconstituting 10 grams of sterile vancomycin powder with 96 ml of sterile water for injection for a concentration of 100 mg per milliliter. 15 ml of the vancomycin 100 mg per milliliter solution is further diluted in 500 ml of 5% dextrose or 0.9% sodium chloride injection, and infused during the last 90 minutes of hemodialysis. For the maintenance dose, vancomycin 500 mg IV, in a pre-mixed bag, is infused during the last 30 minutes of each subsequent dialysis session. DOB should receive gentamicin 75 mg infused over 30 minutes after dialysis. Parenteral gentamicin is prepared by diluting the 75 mg dose with 50 to 100 ml of 5% dextrose or 0.9% sodium chloride injection. Vancomycin and gentamicin doses are adjusted according to serum concentrations measured before the next hemodialysis session, targeting pre-dialysis concentrations of approximately 20 mg per milliliter for vancomycin and 3 mg per milliliter for gentamicin. Subsequent antibiotic therapy should be tailored based on culture and sensitivity results. Antibiotic therapy is continued until blood cultures are negative, no other source of infection is identified, and signs and symptoms of infection have resolved, e.g., resolution of fever and leukocystosis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 525.